everyone. So I am Dr. Mileski, and I'm going to be giving our lecture today. Let me just get my screen up. Alrighty, so we're going to be talking today about prescribing Prism for diplopia and neuro-ophthalmic disorders. So I'm an optometrist at the Emory Eye Center, and I work specifically with our neuro-ophthalmic disease group and see a lot of our follow-ups and work with these patients in regards to their Prism. I have no financial disclosures. And so when we think about double vision, we know that just to simply define it for our patients, it's seeing two images of the same object. And this really can be from monocular reasons or potentially binocular reasons as well. And when we're thinking about monocular reasons, we can think about simple things like refractive error. Is something coming from the cornea, the lens, or the retina in and of itself? Potentially things like an epiretinal membrane, if there's any swelling in the retina, anything that's changing the location of the fovea. However, binocular diplopia is what we really want to focus on today. And what that truly means is that you're not bifoveal, so you're seeing two images of the same object. And so when we're evaluating patients for double vision, our history is really the key to make sure that this is truly binocular diplopia and not monocular diplopia. And there are different questions that you can ask to try to address this. So specifically, if they cover either eye, does the double vision go away? So you want to ask not just about any eye, but specifically, do they cover the right eye, it goes away, and if they cover the left eye, if it goes away. If they cover the right eye and it goes away, but they cover the left eye and it's still present, then that tells you that there's at least a monocular component coming from the right eye. You also want to ask about the direction. Are the images split side by side? Are they more at a diagonal, or are they separated up and down? This can help in your differential of what's potentially causing the double vision so that we can treat it. The duration, has it been going on acutely? Has it just happened in the last few days, last few weeks? Or has it been something that's been present for several years and is maybe now getting more frequent? The location of the double vision, is it just at distance? Is it when you're reading? Is it when you look to the right? Again, this can give us a good hint to the etiology of the double vision. Any associated symptoms, things like headache, eye pain, tearing, particularly in one eye. Again, this can help with our differential if potentially it's coming from the orbit itself. And then any history of an eye turn or abnormal head posture. That can give us an idea if maybe this is more long-standing and it's just starting to decompensate at this point. And so we have different tools during our examination that can help us evaluate for the double vision. And the biggest thing is doing what's called a dedicated sensory motor examination. So first starting with just the sensory system or the eye's ability to have fusion. And we can do this typically in one of two ways, either with a Wirth 4-dot or a Rand-dot stereopsis. So I have the Wirth 4-dot here on the top of the screen, the Rand-dot below. Personally, I prefer Wirth 4-dot. I think it's easier for the patient to understand. It's something that you can easily bring with you if you're doing examinations remotely. And it's actually very cost effective if you have to order this for yourself. It also is very good at giving you information at both distance and near, whereas Rand-dot is very dependent on doing it at near and the patient's prescription being accurate, where I find Wirth 4-dot, that's not necessarily as true. So with Wirth 4-dot, you're going to have a pair of glasses, just like this. The right eye will have a red lens. The left eye will have a green lens. Because of that, you can even do that with a trial frame with a red and green lens. The only thing you would necessarily have to purchase is the adapter here, which can be attached to a pen light, or there are also flashlights that have this as well. And so the right eye will see red, the left eye will see green. And so when this target is presented to the patient, if they have fusion, then they'll see 4 dots. The right eye will see the red, the left eye will see the green, and the white dot can either be red, green, or a mixture of the two. Sometimes patients will also describe it alternating between the two colors. Whereas if they are seeing double, they should see 5 dots, where each eye will independently see the white dot. And if they have double vision where they have esotropia, where the eye is turning in, the red dots will be to the right of the green dots, which is called uncrossed diplopia. Whereas if they have an exotropia and the eye is out, the red dots will be to the left of the green dots. This gives you a really good gauge of potentially what the patient's describing. Also, the patient could be suppressing, even though they might tell you that they're saying diplopia. This is a good indication that this has been going on probably for a longer period of time. And in that case, they're suppressing if the right eye only sees 2 red dots, there's no green, or the left eye sees 3 green dots and no red. After checking the sensory system, we're now going to look at our motor system. And that first just entails just looking at the extraocular motility, seeing how far out the eyes can move in all fields of gaze, making sure you're bringing the eye all the way out to the point where you ideally don't see any sclera. If you see any evidence of sclera on the sides, that could be an indication that potentially there could be a mild deficit. And then to measure it, to give us kind of telling us if it's a aphoria, is it atropia, how the eye is turning, how frequent the eye is turning, and to what magnitude, and looking for specific patterns for double vision is really the next thing that we do, and probably one of the most important things that we do. And so the first thing is a cover test, and you can really do cover testing or Maddox rod. Personally, I prefer cover test, although I do have a lot of colleagues who prefer Maddox rod, so that's really up to you on what you is ideal for your practice. This is just an illustration on how to properly do a cover test in case it's not something that you do regularly. And you can start with a unilateral test, and that's really going to tell you the direction and the duration of the eye turning. So is the eye turning in, is it turning out, up or down, and is it constant or is it intermittent? So you're really going to just be covering one eye at a time and then taking the paddle away. And then after a few minutes, you can do the same thing then for the fellow eye. Again, giving them a target at distance, and then you can also do this at near. For most of the things that we're talking about for neuro-ophthalmic etiologies, most of it will be at distance, although there are a few things that are dedicated purely to near, so we do want to check both. And so what you're going to do is cover the eye and uncover it. And what you're looking for is to see how the eye moves into the resting position. And so if the eye is turning in, when the eye is covered, it will naturally then turn in. And when you take the paddle away, you'll want to refixate and the eye will naturally move out. The opposite is true for exotropias. When the eye is covered, the eye will naturally rest out. And then when you remove the paddle to find fixation, it will then move in. And the same thing for vertical misalignment. So for hypertropias, the eye will rest up and then come down to refixate. For hypotropias, the eye will rest down and then come up to refixate. Now with hypertropias, I often call the hypertropic eye. And so even though there might be a deficit in the left eye, if the left eye is down, I still sometimes will call it a right hypertropia. I find that the nomenclature just makes a little bit more sense, although it can be called either way. So you'll see that throughout the lecture. So again, we are going to cover the eye. The eye right now rests in while it's covered. I take the paddle away, it moves out. And because of that, that tells me that this is an esotropia. Now here I'm covering the eye's naturally resting out. It comes back in to pick up refixation. It moves out. It comes back in to pick up refixation. So this is an exotropia. Same thing here. The eye moves up as it's covered. It comes down, and that's a left hypertropia. And then here, I pull the paddle away. It comes up. It comes up. And so this is either a left hypotropia or a right hypertropia. With your unilateral cover test, if it's atropia, the eye will always be kind of moving and coming back into fixation. Now they can still have aphoria that can be large and could be causing double vision that you may not see if you're just purely doing a unilateral cover test. The next is your alternating cover test. So this will tell you if they have aphoria and the magnitude and the pattern. So this is where we're going to start to introduce the prism to measure the magnitude. And then we're also going to look at this in different directions of gaze to see if there's any specific pattern that puts us towards a specific etiology for the double vision. And so here we're going to cover the left eye, and we're going to quickly go back and forth between the right and left eyes. And here we're seeing that as the eye's covered, it is moving out and it's coming back in to pick up refixation. And so this would be our exophoria. Okay, so now we're going to introduce the prism to measure it. So we're going to introduce the prism, and we're going to start with a low number, and then we're going to slowly start to bring the prism down so that we can try to neutralize the misalignment, with our goal being that we're seeing very little to no movement, Or sometimes I even reverse the movement. So now I create an esotropia, and then I go backwards to make sure that it's neutralized. That's one way that you can check your measurement. And so when we think about what Prism does, a prism is really a refracting lens that bends light. And so we use this in patients with double vision to move the image to where the eye is naturally resting. And so the image is going to move towards the apex or the point of the prism. And so to measure this, we want to put the apex of the prism where the eye is naturally resting. And so with that, this is all assuming right now for the right eye. For esotropias, we're going to put the base out so that the point of the prism is resting towards the nose or where the eye is resting. Exotropias will be base in, hypertropias will be base down, and hypotropias will be base up. Now, if we put that over the left eye, it could potentially change in the direction I have the prism kind of resting right here, whereas it will stay the same, obviously, for the vertical misalignment. So here, for this patient, we said they had an exophoria. We're going to introduce a prism. It's going to be base in because the eye is resting out. And I want to put the apex of the prism where the eye is located. And we're going to move back and forth. It's obviously not neutralized yet. We're going to move back and forth here. We're getting closer. And we're going to move back and forth. We see no movement. And that would be what we record as the magnitude of the deviation. We then want to do this in multiple positions of gaze to look for a specific pattern. This is a patient who has a mild but a cranial nerve 3 palsy. You can see that she has a ptosis on the right eye. When she looks up, the right eye doesn't go up to the same degree as the left eye. And so that would then create a left hypertropia. As she looks down, you can see that the right eye doesn't go all the way down. So now she has a right hypertropia, which is called a reversing hyperdeviation, which is very pathognomonic for a cranial nerve 3 palsy. She also has a very mild adduction deficit here, although it's difficult to see in this picture. And again, that's very pathognomonic for a cranial nerve 3 palsy. Again, when you're looking for these patterns, and that's what we want to do next. And we're only going to do that with an alternating cover test. When you're looking for these patterns in different positions of gaze, really doing a unilateral cover test doesn't give you any useful information. So just an alternating cover test here. We can do the same thing with a Maddox rod. However, this is now going to create a subjective component to the test, whereas a cover test is really going to give you just objective measures. So here we really need the patient to be able to be a big communicator. Sometimes I find with certain patients, this can be difficult for them to understand specifically what I'm asking. But it can give you a good, quick sense of what a pattern is without taking a measurement, or you can also introduce Prism to get a measurement as well. And so with this test, you're going to present a pen light, and then the patient is going to hold a red lens that has lines on it. And the lines can be oriented either horizontally or vertically. When the lines are horizontal, like in this picture here, it then creates a vertical image. And this is going to let you take a measurement for horizontal deviations. So just think if the lines are horizontally oriented, it's going to be for horizontal measurements. And so what the patient will see is a red vertical line and then the white light from the pen light. If a patient has an orthophoria or no deviation, then the red line should bisect the white light. And that's really what you're looking for if you're then going to introduce a prism bar to create it to be neutral. However, even if a patient has a mild phoria that they're asymptomatic for, they still can have a little bit of separation like what we see here. And this is as the patient's viewing this. And so the red line is to the right of the white light, which the red Maddox rod is placed over the right eye. So this is uncrossed, meaning there's an esophoria or tropia. You really can't assess that with a Maddox rod. And that's where usually I find patients have the biggest confusion is of telling me what's to the right and what's to the left. So that is something to kind of take into consideration with it, although it still is a useful and quick test potentially. The same thing can be done for vertical deviations. However, now we're going to flip our lines. So now we're going to orient the lines vertically so that we're measuring for vertical deviations, but the patient will now see a horizontal line. And again, our end point is having this horizontal line bisect the white light. Similar to exotropias, hypertropias will be reversed, meaning if the patient sees the red line below the white light, then that's indicating that they have a right hypertropia. And again, we can introduce Prism to give us neutrality. The other things that we want to consider in addition to our basic sensory motor examination is looking at things like exophthalmometry. Is one eye more proptotic than the other eye? That can tell us that maybe something is localizing to the orbit for the etiology, to the double vision. Taking a look at their eyelids, again, evaluating, could there potentially be a Horner syndrome that's associated with it? Could this be evidence of a cranial nerve 3 palsy? And then potentially, specifically if you have a vertical deviation, you may want to do something called a double Maddox rod. So somewhat similar to what we just talked about with your cover test type of Maddox rod, but here you're going to present the patient with 2 Maddox rod lenses, and this can be very helpful to evaluate for torsion and help you look for differences between a cranial nerve 4 palsy and a skew deviation. Again, more information for more of a diagnosis purpose, not so much for helping with the Prism, but really can help you try to differentiate between these 2 etiologies. So when it comes to treating double vision, the first and most important thing is to rule out a pathological cause, and that can be with neuroimaging or blood work. And this may not be something that you're doing. This may have already been investigated, and this patient's then getting referred to you for Prism, but this is always something you want to make sure was addressed. Specifically, if you're doing your cover test and you're finding a pattern that can be concerning for a specific neuro-ophthalmic etiology. And then the next 2 things to think about are non-surgical causes and surgical causes. And for the point of this discussion today, we're really going to be emphasizing on non-surgical causes here. And so when we think about non-surgical causes, this is where we start to think about Prism, not just for measuring the misalignment, but also for treating it. And this can be done in 2 ways. This can be done with Fresnel Prism, which is a temporary fix, although it can be permanent for some patients as well, and ground-in Prism. The other thing that's still important to always consider is occlusion, because that can also be a better option for some people. And this can be your traditional patching or putting on a patient's glasses with what's called a Bangard or foil. This again can be a temporary thing, so a patient can try it. Because it's a filter that gets kind of just placed on the surface of the glass. It could be ordered in different densities. So it could be just a very mild clouding. You can see it kind of here where the lens looks fogged. It could be just 20/40, 20/60, so it gives a mild blur. However, I find that 2400 to light perception typically gives patients the best result because it's going to create enough blur so that they don't see double, but it still lets them get light to the eye, which a lot of patients find to be a little bit more comfortable than completely patching the eye off itself. If they like this, you can even then order the glasses fogged so that you don't have to have this actual film on the glass. Temporarily, if this isn't accessible to you, tape actually does a very similar thing, although cosmetically it doesn't look as good as fogging the lens or putting this Bangard or foil on it. So our goal with Prism is to really create binocular vision in primary gaze, meaning when the patient looks straight ahead. And oftentimes this means that potentially when they look to the right or the left, they may still be diplopic. And so then really teaching your patient that they may have to turn their head instead of moving their eye to the side because of this. That's very common that we see that. Our goal is always straight ahead at distance and straight ahead for reading. And similar to when we measure Prism, we want to put the apex of the prism, so the point of the prism where the eye is resting. So for exotropias, we're going to prescribe base in Prism. For esotropias, we're going to prescribe base out Prism. For hypertropias, base down Prism, and hypotropias, base up Prism. And potentially these patients may need 2 pairs of glasses if their deviation is different at both distance and near. So because of this, I often take patients out of progressives and bifocals if they need Prism. If they need a higher amount of Prism, I always take them out of a progressive, even if their deviation is equal at distance and near. I find the progressives just end up causing too much discomfort from a visual standpoint, but also they're not looking through the appropriate amount of Prism just from the progressive design. It's not very successful typically. Small amounts of Prism, I can sometimes do it, but most of the time we typically want to take them out of progressives. And so we're going to start here with Fresnel prisms. And so a Fresnel prism is a press-on lens that's going to help alleviate the double vision. It's typically used initially to determine if a patient can adapt to Prism in general, or if we really don't know what the etiology is still, because their alignment can potentially change. If it's a vasculopathic etiology, we know that it can get better over a few weeks to months. And so we might have to change out the prism, which is very easy to do if we have a Fresnel lens. Or potentially, we don't know what's causing the double vision. It might end up being myasthenia gravis. And that would be really unfortunate if a patient paid money to get ground in Prism. That's really not going to work for them. Oftentimes too, maybe we find a neurologic cause for the double vision that can be treated to some degree. And again, that's going to create the deviation to change. And so for all those reasons, we really don't want to go with ground in Prism right away if we really don't know what's causing it and if it's stable. The advantages to Fresnel is that it can be put on the glasses immediately in clinic for relief, assuming that you have a stack of prisms to try with the patient. And that's really what I recommend, is keeping maybe 2 to 3 of each type of Fresnel in your office if that's available to you, because then you can try them on with the patient in the clinic, cut it yourself, which is much easier than having the patient cut it on their own. And then it's something you can give your patients right away. But I always like to try them in the clinic because it gives me a better idea of what they would like, because it can be a little bit different than sometimes what you expect, specifically because of the blur that it causes. Again, it's easy to change these lenses out. Oftentimes with patients who I think they're going to start improving, maybe they have a traumatic 6 or traumatic 4, and we think that this might get better with time, I bring them back about every 4 to 6 weeks, and sometimes we change out their Fresnel. It's lightweight, so if we have to go to higher values, which we can prescribe about up to 40 prism diopters of a Fresnel prism, it's not going to be very heavy. So that's a great thing to think about, and it's inexpensive. One important thing to note about Fresnel prisms is when I'm using it to treat double vision, I only put it in front of one eye because it creates a natural blurry image because of the lines that are on the glass. And so if we put it in front of both eyes, these patients are going to be very uncomfortable. So you only ever want to put this in front of one eye, whereas ground and prism we split. So again, only in front of one eye. I always tell the patient that it's going to be blurry in front of that eye, especially if they close one eye. When they're driving, they're going to get a lot of glare off of headlights because it's basically creating this distortion naturally. It is visible, so other people are going to see the prism, which some people really don't like. And it's hard, although possible, to correct both horizontal and vertical deviation simultaneously. What I often find is that if you are correcting the larger deviation, sometimes patients, because of that blur, aren't that symptomatic for the vertical misalignment. However, you can rotate the Fresnel to try to correct for both. There are mathematical models that can help you do this, although I find that just doing it with the patient in the room is honestly probably the most helpful way to determine what power and how much rotation that you'll need. And so I saw some of the questions from before about how to cut a Fresnel, so I'm going to demonstrate this here. And so I'll kind of talk you through it. So this is what the Fresnel prism is going to look like. And the first thing that I'm doing is trying to figure out the way that the lens is, that the Fresnel is oriented, so where the prism is. And so personally, I just like to run my finger along the edge and try to find where the base is. Obviously, my nail will kind of get stuck when it hits the prism, whereas the other way, you can easily kind of run your finger across it and it should be smooth. There's a rough side of the Fresnel and a smooth side on the opposite side. The smooth side is what we're going to physically want to put onto the lens. The rough side is going to be on the outside. So first, we're going to find the orientation of the prism. Okay, I can see here, it's going to be oriented face out. We're going to be correcting esotropia here. And you can see here how then it shifts the image. Okay, and so again, I'm just going to confirm the way that it's oriented. I always like to start at the edge because potentially you can reuse the prism, which can then be very helpful for your patients, even from a billing standpoint, if you can use a prism potentially for 2 patients. And so I'm making sure that the lines are perfectly straight up and down at this point. I'm putting it down on a hard surface. I'm doing this from home. So typically I'm going to put it on something a little bit cleaner. I'm going to clean the lens as well. And then I'm going to use something, either a marker or a pen, to trace out the glass. Again, the smooth side right now is on the lens. And I always put these on the inside of the patient's glasses. I find that it keeps the prism a little bit cleaner than if it were on the outside. It also keeps it to stay on a little bit better. And then I'm going to now cut the prism. And I typically try to cut within inside of my line so that you're not going to see that marker. And it's better actually for the prism to be a little bit smaller than the frame then to be a little bit bigger. If it's not on the lens in one location, it's getting lifted by the edge of the frame, that prism is going to come right off. It's going to get dirty really quickly. And so I much prefer a prism that's going to be smaller than bigger, and that then lets the patient potentially take it off to clean easier. So I like to leave a little nook potentially right here in the corner so that the patient can easily take it off. So here I see that there's a loose edge. And so I'm going to take it off. And I'm going to trim it in that area as well. And then put it on the inside of the lens. Make sure there's no loose edges. Again, make sure the lenses are straight up and down, and then just smooth it out onto the lens to try to get out the bubbles, which can sometimes be the hardest part. And you can see here, I have it, this is a 20 actually, so that's fairly high, and it's really not that cosmetically noticeable on the glass. That glass maybe looks a little bit dirty, but in general, it's not creating this terrible cosmetic look, although it is more noticeable than if you had ground and prism. And so for ground and prism, this is really going to now be built into the glasses prescription. So you definitely have to have an updated refraction if you're going to be giving a patient ground and prism. And so this is great to use when you know that the deviation is stable or you know what's causing the double vision. And so the advantage to this is you're now going to have two clear lenses. There's going to be nothing on the surface of the glass. And it can be split between the right and the left eye to make the glasses appear symmetric. So I always split my prism. So if I'm prescribing 10 base in prism, I'm going to put 5 in the right eye, 5 in the left eye. The only time that I consider not putting them equal, if let's say the patient's very myopic in one eye, they're a -5 in the right eye and only a -1 in the left eye, then I may want to put more prism in the left eye. And occasionally I'll just put that to the recommendation of the optical, what would be the best to make the glasses look symmetric, because they can really run better calculations within their labs themselves. Another advantage is that's not easily visible to other people. And so oftentimes from a cosmetic standpoint, patients prefer this because people really won't know that patients have prism in their glasses unless it's very, very thick. And it very easily corrects both vertical and horizontal deviations. So I can put 5 base in prism in the right eye and 3 base down, and it's not going to be difficult for that. And we can really kind of demonstrate this just even in the clinic by putting this in a trial frame. It'll give the same effect. Again, this is better doing it in a single lens and not potentially doing it in a progressive. It's much more successful when we think about it that way. The biggest disadvantage is I can really typically only put up to 20 prism diopters, 10 in each eye. That's still pretty high. Some labs actually don't prefer putting that high of an amount. Some labs only prefer up to 6 to 8 in each eye independently. So there is a max amount of prism that I can put in the glass. It does take some time to be made, typically longer than what it would be without prism, and it can be very expensive. Here, at least, it's typically about $10 per diopter of prism. And so if I'm putting 20 prism diopters in a glass, that's an extra $200 to the patient. Again, that's a rough estimate. Every optical obviously is going to be different, but it definitely adds a cost to the patient. And they may also need multiple changes to the glasses. I always bring these patients back because sometimes what we get in the exam room doesn't correlate to what they need in real life, and we might have to make a change. And because of that, you always want to bring these patients back in about 4 to 6 weeks so that you can readdress that. Occlusion is something I still just want to mention because it sometimes is the best option, and that's okay if occlusion is the best option. Our goal is to create with occlusion monocular vision to alleviate double vision. It's obviously not it's not ideal because you're then going to kind of lose binocular vision. It also cosmetically sometimes isn't an ideal option. However, some patients are very, very sensitive to the fact that they may be asymptomatic in primary gaze, but when they move their eyes in any other direction, they're going to have double vision, and it can be very bothersome. And so because of that, sometimes they prefer to be occluded. It also, they don't need additional glasses. Sometimes you can even do this with a contact lens, which can be cosmetically an advantage. And it also gives them immediate relief and is inexpensive. And so it's still something to always think about in the acute stage, but sometimes even in the chronic stage as well. So when we're thinking about double vision, we want to think about our differential. And so we're going to start purely here with just our muscles. And so with this superior rectus is going to elevate the eye, intort the eye, and adduct the eye. The medial rectus is going to be purely adduction. The inferior rectus is going to do depression, extorsion, and a little bit of adduction in the tertiary action as well. And the inferior oblique is going to create extorsion, depression, and abduction. The lateral rectus, pure abduction, it's only a primary action. And the superior oblique is going to create intorsion, depression, and abduction. And so if we have a deficit here in one of the cranial nerves, these are the things that we can expect. So for a cranial nerve 3 palsy, similar to that picture that I showed you before, we're going to have a lack of elevation, depression, adduction, and then they may also have a ptosis because cranial nerve 3 innervates the levator, and the pupil may be big because it naturally creates constriction of the pupil. For a cranial nerve 4 palsy, because the superior oblique does intorsion, depression, and abduction, these patients typically have a hypertropia in that eye that gets worse when they adduct because the superior oblique is a pure depressor when the eye is adducted. And they also then will have excyclotorsion of the eye. Again, that's how you can differentiate it from a skew deviation. For a cranial nerve 6 palsy, this is probably the thing that people see the most often. It's going to be purely a lack of abduction. It does not have to be 0. Sometimes it could be, just a 20% deficit, and you can still have symptoms. The next thing to always think about is a deficit at the neuromuscular junction. So where the nerve is sending a signal to the muscle, and that's what we typically see in patients with myasthenia gravis. Sometimes these patients have double vision that's worse at the end of the day. It could be very variable. It could change direction. Sometimes it's horizontal, sometimes it's vertical. And typically these patients are not good candidates for Prism because it can change. The 1 minute you check the patient's deviation, they leave, they go home, and the deviation can be completely different. So often occlusion is a better option for these patients. Sometimes when these patients are treated, their double vision can go away. And very rarely I've seen patients who are treated and controlled and have a stable deviation. And in those cases, you could potentially consider starting with a Fresnel, although it's definitely doesn't happen as often as we would like. And then finally, different causes that can deal with the brain. Typically, we think brainstem in general. That's where all of our cranial nerves that are going to innervate our muscles are starting. However, it can happen with any of the pathways, even sharing information with the brainstem as well. And so these are our big things on our differential. I'm not going to go into these to the same degree since we're purely talking more so about treatment, but looking for different things like an internuclear ophthalmoplegia. These patients will have an adduction deficit, so there'll be an exotropia, so they'll need base in prism. Gaze palsy, there'll be a physical area where they won't be able to move the eye to. A skew deviation like a 4, they'll have a hyper, but the eye will be encyclotorted instead of excyclotorted. Dorsal midbrain syndrome, they can have a deficit in their vertical eye movements, or neurodegenerative disease. And this is a lot of the patients that I see as well. So different things like Parkinson's and progressive supranuclear palsy. These patients often have convergence insufficiency and need Prism at near to help be able to read comfortably. Obviously, our cranial nerve 3 palsies, we always want to think about 4 and 6, myasthenia gravis, as we mentioned, and then something purely localizing to the muscle itself. And so when we're treating neurologic conditions with Prism, like I said, we always want to make sure that that etiology is known or under investigation. We then want to update the refraction at both distance and near. Specifically, like I said, we may need 2 pairs of glasses. We want to do a cover test or a Maddox rod without any prescription at distance and all positions of gaze, which means you may have to create a big target to be able to do this if the patient has a high prescription. Occasionally, I even just put a white dot on the black background to be able to do this, but we don't want them to have their glasses on because if they turn their head to do this with the glasses on, they're actually going to get an induced prism effect from their glasses itself. We then want to check their cover test at distance and near with their updated glasses prescription on, and this can be done with a trial frame or potentially even using the patient's current glasses. And then we want to trial Prism at both distance and near. So for horizontal Prism, we're going to start with I typically start with about half of their objective measurement, and then we're going to move the bar up until we get fusion. And so the Prism can be placed over either eye. So let's say, for example, I measure 16 Prism diopters. I typically start with an 8, and I present a horizontal line for the patient and see if they have fusion or if they're still diplopic. Like I said, it can be placed over either eye. The only time I put it over the paretic eye is if I'm putting the patient in a position of gaze where they can't move the eye to. So let's say the patient can't abduct and I'm having the patient turn their head, then I'm going to want to put the prism over the left eye here so that I can already move the image to where the eye is before I check the measurement. Otherwise, you're not going to see any movement. You then want to move the bar up and down by about 2 prism diopters once you get fusion to see when it breaks, or even when it starts to become blurry to the patient. Sometimes they get blur before it breaks into diplopia. And then that median point is typically my end point. And then I want to recheck their fusion to see now, do they see 4 dots on the Worth 4-dot test? For vertical prism, the biggest difference is I actually start with my objective measurement, because typically there isn't this compensatory movement that patients can create to be comfortable. And so I typically start with what I objectively measure. Again, it can be placed over either eye, and I'm going to move the bar up and down by 1 to 2 prism diopters until fusion breaks. And again, that median point is going to be my end point, and then I'm going to recheck their fusion. Sometimes with vertical deviations, I like to trail frame them because I can make a prism diopter, sometimes even a half a prism diopter change. Whereas when I use the bar, sometimes I have to move it by 2, and that's too much. When we're trying to combine prism for horizontal and vertical, you want to always neutralize the larger deviation first. So if your patient has a 20 exotropia and a 5 hyper, neutralize the 20 first and then start to incorporate the vertical prism after. Sometimes I'll try to move the images until they are lined up in one direction. And so if I want to neutralize my horizontal deviation first, I'm going to try to make the images so they're right on top of each other. And then I'm going to start to introduce the vertical prism over top. And then you may have to start to tweak it. So oftentimes you need 2 hands to do this. Or like I said, you can do it in a child frame. Sometimes that can be easier. This is specifically when you're doing 2 different types of prism at the same time, it can be very time consuming and challenging with variable results, but it is obtainable. You just have to take your time to do this. So when we're starting to think about prisms, like I said, we're going to potentially do Fresnel prism first, specifically if the etiology is unknown and if the deviation may change. Then we'll consider ground in prism, specifically if after we know the etiology, if any deficit remains, or we know that it's stable, or we know the cause. And we'll consider referral for surgical intervention potentially if patients are interested in this. So when do we refer for surgery? So I usually refer for patients who have constant diplopia and their cover testing has been stable for about a year. If we get to 6 months, you can think about putting the referral in at that point because it may take time to get in with your surgeon and they may want to evaluate them themselves. But typically, most surgeons won't do surgery until about a year after things have been stable. Also, when I know that it's probably not going to progress anymore. Potentially, maybe this patient had a cranial nerve 3 palsy and it's been stable for a long period of time and they're not undergoing any treatment for it at this point. If they're able to achieve fusion with Prism, so this is very important. If you cannot get your patient to fuse with Prism, they probably won't fuse with surgery. Because really with Prism, instead of moving the image to where the eye is located, we're really now moving the eye to where the image is. And so it's still doing a similar thing. And if we can't get fusion with Prism, it really won't be able to happen with surgery either. And so that's really one thing it's always important to remember. And similar to Prism, the goal is going to be single vision and primary gaze. They still may be diplopic on other gazes. And so you want to make sure that your patient is aware of that because that can be one thing that patients are hesitant about then with surgery because they're not going to be perfect in all positions of gaze. But from a cosmetic standpoint, from a glasses standpoint, this is still a really good option for some patients. So I always talk to them about surgery if they're a good candidate. Also, you want to make sure their deviation is large enough for surgery. So in general, for hypertropias, most surgeons won't do surgery unless it's about 5 to 6 prism diopters or larger. And the same thing for horizontal measurements. Typically 8 to 10 prism diopters or larger, they'll do surgery. Anything less, their room for error is too great and they typically do not operate on those patients. So you also want to make sure the measurement is big enough for them to be a surgical candidate. So I saw also a lot of questions about yoked prism. For me, I see most patients with double vision, so I often don't do yoked prism for hemianopsias, although some of my low vision colleagues do, so it is something to consider. Oftentimes, we often think about it for nystagmus, so sometimes I see patients in regards to that to try to yoke them out of their position of the nystagmus or an abnormal head posture. An important thing to remember, though, is that a 2-diopter prism only shifts the image by 1 degree. And so you really need a lot of prism to move the image in both directions. And what a yoked prism is, for some people who may not know that, is putting the prism in the same direction in both eyes to move the image. So if you want to move the image up, you're going to put base down prism, it'll shift the prism up. For visual field defects, you want to put the prism and the base in the direction of the defect, so it shifts the prism out of the visual field defect. But again, if you're doing this in ground and glasses, you're going to shift everything, and you really can only put 20 prism diopters, so you're only going to shift the field by about 10 degrees. You can put higher amounts with Fresnel prism. However, it will require 2 in front of each eye, which will require blur and distortion. And because of that, it's better to place it sectorally, like in this image here. And so the patient can look straight ahead, but then kind of move a little bit into their area of their defect to shift the image to the side. So again, this can be done with sectorial prism or potentially with the Peli lens. With both of these things, you really need a really good rehab team to work with orientation and mobility to be successful with this. It also can be used in visual neglect, and we see this commonly after right brain stroke, and where patients will then ignore the left side. You may also see that they kind of have this compensatory head turn to the right because they're, again, going to be neglecting the left side. And we see commonly that patients have an extinction phenomenon with visual neglect, where if you present a stimulus on the right side and the left side, they'll ignore the image on the left side. And so prism adaptation can be used with these patients with yoked prism. So typically we yoke the prism to the right, and the patient will then perform like finger to nose exercises, basically. And what you'll find is that they'll overcompensate to the right because the prism's in place. And then with time, as they're doing it, they'll start to adapt to move to the left to make up for that. Then when the prism is removed, they'll naturally overcorrect to the left, and that will help them start to be aware of the field to the left side. Typically, it takes about 10 to 20 treatments for them to have any benefit, again, done in the acute phase in the rehab setting. The biggest challenges otherwise we see with prism are if there's other ocular comorbidities like maculopathies. This can, again, change the fovea in one eye. So what you actually measure can be different than what the patient subjectively likes. If there's asymmetric acuities, we might have a clear image in one eye, so they're 20/20. If the other eye is 20/70 with an epiretinal membrane and there's distortion, I'm now trying to put a clear image on top of a blurry image, and that might not be ideal for the patient. Sometimes that then creates just a blurry image, and so that can definitely be a challenge. In patients who have other visual field defects, whether it be a homonymous or maybe they have severe glaucoma and they have a dense inferior arcuate, sometimes as I'm moving the prism, I can move them into their defect and they end up suppressing. That can be advantageous or it can be a disadvantage. It really depends on what the patient's goal is. So that can definitely become a challenge. A big challenge I see is patients not wanting to come out of their progressive glasses or have 2 separate glasses because it can be challenging to them. Typically, it's the biggest complaint that I have for patients, specifically when they go to the grocery store, they have to change their glasses, and that's really cumbersome. But sometimes I'll let them try doing it in a progressive, and 9 times out of 10 it's unsuccessful, and then they end up going back to the 2 pairs of glasses. Another problem is if they need more than 40 diopters of prism. Sometimes we have patients with traumatic 6s. That's probably the best example that I've seen, where their measurement might be 60 prism diopters, sometimes 50 prism diopters. And so sometimes I'll actually give them some ground in prism so that I can successfully put a Fresnel over top of them. And so that's usually the route that I go, but sometimes occlusion is a better option. Nystagmus can again be a problem, specifically if it's in primary gaze, because I'll have a shaky image that I'm trying to put over another image, which can create a lot of blur. And then if the patient's suppressing, sometimes patients are suppressing and just getting intermittent diplopia, and I can have a really hard time with fusion when that occurs. And so those patients can be very challenging and time consuming. Again, we can occasionally get to an endpoint, but sometimes it's okay to let them suppress as well. So let's just go through a couple cases here for the next 5 minutes so that then we can get to some of the questions. And so we have a 54-year-old male who's complaining of blurry vision and eye fatigue for about 2.5 years. He's been noticing really just gradual blurry vision at distance and with driving, and specifically when he looks to the left. And even then he almost notices some double vision when he's turning his face to shave. He notices this both with and without his glasses on. His ocular history is remarkable just for myopia. He does have high cholesterol and depression and takes medications for that. He has no allergies and is a current smoker. And so on his examination, he's 20/25 in the right eye, 20/20 in the left. He is myopic and presbyopic. He does correct to 20/20. His pupils are normal. Really everything else is normal. Normal pressures. He is mildly proptotic, but equal between the two eyes and normal for his ethnicity. And anterior and posterior segment is unremarkable. However, when you look at his extraocular motility, he has a mild left abduction deficit. When you present the Worth 4 dot, he has diplopia. He sees 5 dots total, 2 red and 3 green. When you do his cover test at distance and near with his glasses on, he has a 12 esotropia at distance and a 6 esophoria at near. And then you take his glasses off, you do cover test in multiple positions of gaze. And you can see that he has this 12, again, I'm doing alternating, that's why I'm saying esophoria, 12 esophoria that goes away when he looks to the right and then increases to 25 when he looks to the left. So here we know he has a left abduction deficit. We have a broad differential, right cranial nerve 6 palsy. This could be myasthenia gravis, it's variable, thyroid eye disease, potentially something in the orbit, or even Duane's retraction. The good thing is that it's isolated, there's no fatigability, and it's been a gradual change over the last 2.5 years. And so we're gonna do a poll here. And so what type of prism at this point would you like to prescribe for this patient? So we have base in Fresnel prism, base out Fresnel prism, base in ground in prism, and base out ground in prism. All right, so most of you would like to prescribe base out Fresnel prism, and I agree with that. Fresnel prism is definitely the best option because we don't know the cause. So we definitely would want to stick with Fresnel, and we said he was an ESO deviation. So the eye is resting in, and so you want to put the apex where the eye is, and so that means it's going to be that triangle. So the base or the edge of the prism will be out. So we started with 6 base out prism. He was still diplopic. So I started with half of what I measured. I measured a 12. So I started with a 6. So I increased his prism to 10 to obtain fusion. I then again moved the bar another 2. He had improved clarity when I went to 12, but it was blurrier when I increased it to 14. So I stuck with the 12 base out prism and applied it as a Fresnel. This is a temporary fix. Even though he had less prism needed at near, he was able to tolerate it at near. And so we were able to do it just on his regular glasses, and an MRI was ordered to determine the etiology. And here he had a small meningioma right on the clivus. Again, this is the pons, so the 6 is going to exit the pons and it's going to kind of hit this meningioma. And so this was the cause of his double vision. He came back 4 months later. He already saw neurosurgery. He decided that he just wanted to monitor with MRI. He was not interested in radiotherapy. However, he was bothered by the cosmesis of the Fresnel and requested ground in prism. I rechecked his measurements. At this point, he was stable, and so we educated him that it could change, but he still wanted to do ground in prism, and so we then created his regular glasses prescription with 12 base out prism split between the right and the left eye, 6 in each eye. At his 8-month follow-up visit, he had worsening diplopia, and now he had an increased left abduction deficit. And so now when we recheck his measurement, he is now at 25 esotropia compared to his original 12. And so at this point, we fit in with a 20 Fresnel over his 12 to give him a temporary fix. He was able to tolerate this at distance. He was just going to take his glasses off because he was myopic for reading. And we now sent him to radiation oncology to get treatment because he now had progression. He came back 4 months later. He had just finished radiation about a month ago. He was hopeful to do ground in prism. He actually took off the Fresnel because he just didn't like the way that it looked, even though he was diplopic. He was just turning his head instead. And when we rechecked his measurement, he was now in 18 esotropia, so less than what we measured originally. And so we fit him with a 12 base out over his ground in prism because he really needed 24, which was just too much to put in the glass. Like I said, 20 is typically our max. And he was very interested in surgery. We told him that our surgeon probably wasn't going to do anything at this point. However, he was very adamant to be referred for surgery. And so we sent him up with our surgeon. Again, he followed up with the surgeon. His measurements were stable, but he still was going to wait several months before he considered surgery in this patient. All right, I'm going to do one more case here. So we have a 72-year-old male who is complaining of blurry vision in the right and left eye. He notes a hard time specifically looking up and down. He has a hard time reading small print like the newspaper. Also has some hard time seeing the TV controls on his remote. And he has now gone through multiple pairs of glasses without improvement, and he's currently wearing progressives. His ocular history, he has cataracts and dry eye. He's not taking any eye drops. His systemic history has arthritis, atrial fibrillation, high blood pressure, high cholesterol, sleep apnea, and progressive supranuclear palsy, which is a neurodegenerative disease. He takes medications for those conditions, no allergies to medications, and the rest of his history is really unremarkable for what we're talking about here. His best corrected acuity, he has 20/20 in both eyes. Pupils are normal, as are confrontation fields. His motility is restricted. We'll show you that in a minute. His eye pressure is normal, and he has a reduced near point convergence at 20 centimeters. And so when we look at his motility, he has both a supraduction and an infraduction deficit, as well as an adduction and an abduction deficit, which is very common in what we see in patients with progressive supranuclear palsy. They often have this vertical gaze palsy and a hard time moving the eyes in general. He has a 6 exophoria at distance and has actually fusion on Wirth 4 dot, but at near he has an 18 exotropia and diplopia. His anterior segment examination, he has some dry eye. Again, similar to Parkinson's, we see these patients blink less often. So they can actually have a monocular component to their double vision as well. So we want to make sure we treat the ocular surface in addition to giving them Prism. And so we're going to do another poll here. So we have a patient who has convergence insufficiency in the setting of progressive supranuclear palsy. So what type of Prism would you like to prescribe? Just a reminder, he has an exotropia. So base in Fresnel, base out Fresnel, base in ground in Prism, or base out ground in Prism. All right, so the consensus was base in Fresnel Prism, base in ground in was second. So actually, because we know what caused his deviation, we know he has progressive supranuclear palsy, I actually gave him base in, so direction was correct, ground in Prism. So I updated his glasses prescription and I trial framed his near prescription because that's where he was symptomatic and where he had diplopia. He measured, just to remind myself, 18 exotropia. I started actually with 10 base in at near. He was still diplopic. That's very common in patients who have neurodegenerative disease. Often we have to give them a little bit more Prism. I increased it to 14. He did have fusion, and it was blurrier when I decreased it to 12 and 16. And so we ended up sticking with 14 base in Prism. Now for him, he has an infraduction deficit in both eyes. So I actually tried to yoke the Prism as well. So giving him the horizontal and then introducing 2 vertical Prism bars to try to yoke the material up, since he could not move his eyes down to be able to see it. But again, I would have to yoke it too much. I could probably only get it at about 20 degrees up. And I really needed to bring it up significantly more than that for him to be able to see it in a normal range. And so he did not respond to yoke Prism. I also tried a little bit of Prism at distance just because he did have a moderate exophoria, but he didn't notice that it was any more comfortable or clearer. And so I took him out of his progressives. That was probably his biggest issue. He physically couldn't move his eyes down to even use the progressive. And so we're going to fit him with just near vision only glasses with ground in Prism. I started with a 14. I also wanted him to hold his reading material higher, or if that ever became difficult for him, to get different visual aids to bring his reading material higher, like a reading stand or even just elevating things. This is often what I tell patients, even with progressive supranuclear palsy, when they're eating, it's helpful to elevate the food on some sort of surface. I also prescribed him a separate distance pair of glasses without Prism and brought him back in 4 to 6 weeks. Okay, I'm actually going to skip this case just so we have time for questions, because it really just talks about occlusion. So in general, Prism can be challenging and time consuming. And so you really want to make sure you're scheduling appropriate time slots. Often these patients need about 45 minutes to an hour, maybe 30 minutes for a follow-up. You want to make sure that a neuro-ophthalmic etiology has been worked up either by yourself or by the referring provider. And if you see something that seems to be different than what that provider got, you want to make sure that's always getting addressed first, because sometimes this can be a life-threatening condition. You want to always set patients' expectations for Prism. When I see a patient for the first time, I always tell them that Prism does not work for everybody. And specifically, if patients have other ocular comorbidities that can make it more challenging, it may only be successful in certain positions of gaze so that they know what to expect. I always bring them back for a follow-up in 4 to 6 weeks to make sure that one, the glasses were made correctly. So I always read them myself. And don't be afraid to make changes to the glasses at this point. Sometimes I bring these patients back and I need to increase their prism. And so I always issue them a doctor's remake. Again, I bring them back in that shorter window of time so that they could potentially go back to their optical and get it remade where there's not a charge to them from the optical. That's at least true here in the US. I don't know from an international standpoint how that works. But that's always something to consider is that, and I tell people from the beginning, we might have to change the glasses. It might not be successful in your normal activities. And it's sometimes okay to recommend occlusion. If you can't get your patient comfortable with Prism, if you can't get them to fuse, or if they're too uncomfortable when they look in different directions of gaze, occlusion is an okay option. It can be a patch, it can be a foil to give them, again, some light to the eye, or sometimes if they're really bothered by the cosmesis of that, pupil blocking contact lens can be a great option for people, or sometimes even a high plus lens so that they still get some light to the eye can do a similar thing. All right, so let's look over some of the questions here. Okay, so I'm going to start from the top here. And if anything got addressed in the lecture, I might just skip over it. So can prisms be prescribed in progressives? They can, but if I do it, I usually do it in very low amounts, like 2 to 3 prism diopters. I often find that any higher amount, patients are very uncomfortable or they're not looking through the appropriate amount. If a patient is adamant about trying a progressive, I usually caution them that it's probably not going to work, but if they really want to try it, we can do it. And typically 9 times out of 10, we have to remake the glasses. How do you prescribe prisms for vertical and horizontal? As I said in the lecture, typically this works a little bit better with ground and prism. I'm going to trial frame them first in the room, and then we could potentially build it into the glasses. With Fresnels, we do have to rotate the prism, which can sometimes be successful, sometimes it's not successful. So something that we can always think about. Comment, I prefer to name the tropia by the tropic eye rather than always naming the hyper eye. I think that's completely fine. Again, it's really going to be whatever you prefer. How do you address a patient if there's a difference between distance and near? 2 pairs of glasses, always. Is double vision examination, how useful is lid evaluation? It's typically more so if you want to know, if you don't know the cause. So if you're looking to see if there's any associated symptoms that can help you determine what the etiology could be, specifically for cranial nerve 3 palsies, or if you think there's an associated Horner syndrome, that can help you localize along the pathway of the extraocular, the nerves where the deficit might be. How can you say which eye has torsional deviation with Maddox rod? So you're gonna, it's better for double Maddox rod. And so let's say your patient has a right hypertropia. I always, again, refer to the hypertropic eye. And so when I'm doing double Maddox rod, I'm gonna cover the one eye and then rotate the Maddox rod to see where it lines up and to see if that eye is intorted or excyclotorted. And so typically I do it kind of based on that. So if the hyper eye is incyclotorted, then typically that's a skew deviation. If the hyper eye is excyclotorted, then typically it's a skew deviation. If both eyes have the torsion in the same direction, it's typically bilateral. Maximum ground and prism, 20 prism diopters. How do we prescribe ground and prism, or how do we prescribe vertical, which is incomitant? So again, typically, like I said, I do just primary gaze. So distance, I'm going to give them primary gaze. And reading, if they're looking down, I'm going to take that measurement and have them hold their reading material where they typically would, and then I'm going to give them that prism. So I educate them that if they move their eyes, that they may still be diplopic. Unfortunately, there's really not a good lens like a progressive that can create a gradual change in the prism. That hopefully will be something that maybe will be invented or created, but right now that's not a good option for people. We're both horizontal. I think we addressed that question already. Can you explain how to differentiate cranial nerve 4 and skew? So I was just briefly doing that. So again, you're going to look at the hyper eye. You're going to have the patient turn the Maddox rod until it creates for them a vertical, a line up and down, or side by side, you can decide. And then you're going to look to see if that's, if you're doing a right eye and a horizontal, if it's turned in, then that's telling you it's in torsion, which is going to be a skew. If it's out, that's going to be a 4. I personally don't use the Tangelli test for oblique diplopia. I know some people do, but I just don't do that in my practice. Frequency for Prism for aphoria. Typically, I see it in decompensated phorias where they have some control, a decent amount. So it's not all patients have neurologic etiologies. Sometimes they get referred to the Neuro-Ophthalmic clinic and it's just a decompensation of a phoria, and that could be at distance or near, and we have to give them Prism. So it's probably not the majority of my patients, but it's probably about maybe 10–15%. For now, I'm not quite sure what that question is. With a bifocal, maybe it was a bifocal, you can, again, putting it on the inside of the glass is better because the lip of the bifocal can sometimes cause the Fresnel to lift up. But again, you'd want to make sure that they're comfortable at distance and near with it. Otherwise, sometimes if it's just distance, I cut just the top of the glass if they're okay with the image jump when they look down. So again, that's why it can be advantageous to do it in your exam room. Fresnel big are more comfortable for patients if placed on the non-dominant eye. That's very true. So that's a good point. So oftentimes I demonstrate the Fresnel over both eyes to see which eye they prefer having it over. Sometimes if they have a big restriction, I'll put it over the paretic eye so that their field of vision is a little bit better. But I typically demonstrate it over both eyes to see which eye they feel more comfortable in. That's a great point. Removing the lens and using a razor blade to cut the Fresnel makes a beautiful edge. I agree if you have that available to you. I usually only have scissors in my clinic, but yes, potentially cutting it with a razor is going to make it a little bit better. Base are written out for Fresnel, which side base is, and if we cannot assume if the image shifts up. Yep, so sometimes, especially with low prism diopters, it can be hard to know the direction or feel the edge. And so sometimes I'll put it up to a straight edge and see how the image moves. And that could be a good way to just to confirm that you're orienting it in the right direction. In which conditions prescribe Prism binocularly and monocularly? So again, for ground and Prism, I always split it between the two eyes. For Fresnel Prism, I only put it in front of one eye because it creates that blur. If there's a monocular component to the double vision, I always treat the monocular condition first, and then we consider Prism, because otherwise if it's monocular and binocular diplopia, I'll never be able to create fusion. I think we already addressed the lids. Can we stick Fresnel on the front surface of the glasses? You can. I just personally find that you get more buildup on the Fresnel when that happens, and so I like to put it on the back surface of the lens. How to use induced prism decentering? I personally don't do this. It definitely can be done, but I would have to work with an optical for that to be done personally, but people do that. What conditions would relate to stable deviations? So thyroid eye disease at some point typically will burn out, and so they might be left with a deviation after that, and so that's going to be stable. In patients who have, for instance, our patient with a cranial nerve 6 palsy who had a meningioma, after they get treated, if he was not interested in surgery, potentially then after a couple months, we could do ground in Prism. I do that again pretty often. All my neurodegenerative patients, typically I do ground in Prism. And then, sometimes it can change, but usually it's not changing that frequently that we have to change the glasses every couple months. It's usually maybe 6 months to a year, usually closer to a year that we have to make the changes. I'm going to do 2 more minutes of questions, and then I'm going to have to sign off here. How do we calculate the oblique orientation of the prism? So there are websites that can help you do that. I don't know them off the top of my head. There are also ways that you can honestly just draw a triangle and then use your hypotenuse to know the correct orientation. Personally, I cut the prism just a little bit smaller and I rotate it with the patient in the room. I find that it's a little bit more accurate. In case of face out prism, would you perform prism adaptation test, progressive prism adaptation before finalizing the amount? I personally don't do that. I don't have a lot of experience with that to see. I usually just frame it in the room, either with a Fresnel or in the trial lens kit, and I actually have them just walk around the clinic to make sure that they're comfortable. You can use Fresnel for torsion, again, correcting the horizontal and the vertical together, although it does have to be rotated, which can be challenging. Would you recommend using a Fresnel Prism trial set in the event we do not have Prism sheets available to us? Yeah, if that's available to you, I think that's a good option. Again, if your patient gets the Fresnel ordered, I would cut it yourself, because every patient I've ever tried to give it to cut themselves, I think all but one have been unsuccessful. You can use Fresnel horizontal in one eye and vertical in the other, but typically it creates so much blur that patients don't like it. I've had one patient who requested it. They didn't like me turning it, but I showed them the Fresnel in both eyes and they loved it. But that's very few and far between. It typically can only work if you're doing a very small amount in the one eye. So I think his vertical was only like a 2 prism diopter, so it didn't create too much blur. But if you hold it for Fresnel, it creates a lot of distortion, so it's not ideal. All right, I'm going to do one last question here. On what grounds would the prism be split between both eyes? So even if the deviation is binocular, so let's say you have a right esotropia, I still split it. So the reason for splitting it is to make the glasses appear symmetric. That's the only reason for splitting it. You could put all the prism in front of one eye, but it's going to make you actually then see the prism. So for an esotropia, you're going to have a high amount of base out prism that cosmetically will be noticeable and probably will be more uncomfortable for the patient. And so I split it from a cosmetic standpoint, a comfort standpoint. And so even if the deviation's in front of one eye, splitting is really just to make the glasses appear better, get less aberration, and just be more comfortable in general. Okay, I'm unfortunately going to have to stop here. I know we got a lot of questions. I'm happy to share my email if that's a possibility. If anybody has any questions that I did not, I just saw here, how do you prescribe prisms in hemiopic patients? I personally don't do that. I refer that to low vision patient, our low vision rehab team to do that, because again, they usually need to work with a rehab or orientation and mobility specialist for that to be able to go kind of hand in hand. So that is all the questions I'm going to be able to answer today. But again, happy to share my email if you guys have any other questions about prescribing Prism, or potentially we can even do another lecture with maybe even more in-person video demonstrations. All right, have a great rest of your day.